Okay, good morning, everyone. I'm excited to be with you today to talk about breast ultrasound, and this lecture is going to focus on a BI-RADS update. My name is Heather Greenwood, and before I begin, I just want to thank both two of my colleagues, Drs. Lori Sterkowski and Jessica Hayward, who helped put together a great portion of this lecture. So just to introduce myself, again, my name is Heather Greenwood. I'm an assistant professor of radiology at the University of California, San Francisco, and I'm in the breast imaging section. A lot of my research focuses on breast MRI and high-risk breast cancer screening. And again, today we're going to talk about breast ultrasound. And just to note, I have nothing to disclose. So let's start. This was a 47-year-old woman. She came into us with a palpable lump. And we see that we got a CC, a craniocaudal, and our lateral medial, lateral oblique view. And we have this BB over where the patient feels the lump. And in this case, at kind of the edge of the mammogram, we're seeing this high density irregular mass. And so whenever we see a finding such as this, or a patient feels something concerning in their breast, after the mammogram, we're always going to proceed with an ultrasound. So here we went on to this ultrasound of that spot on the mammogram and the area that the patient was feeling, and corresponding to her palpable lump and that finding on the mammogram, here on her ultrasound, we see this corresponding hypoechoic irregular mass with angular margin. So ultrasound helps us make the diagnosis that this is in fact not a cyst, it is a suspicious solid mass. And then she underwent ultrasound-guided core biopsy of this mass. So ultrasound is very key in breast imaging for both diagnosis and to enable us to do tissue sampling of suspicious breast lesions. And so the message of my talk today truly is that breast ultrasound is central to the diagnosis and sampling of breast lesions, and optimizing your technique will help you make the right diagnosis. So the goals of my lecture today are going to be reviewing the BI-RADS for breast ultrasound with a focus on the most recent updates. In 2013, the second edition for ultrasound BI-RADS was published. This was along with the fifth edition for mammography and the second edition for MRI. And today we're really going to focus on breast ultrasound, and we're going to start by reviewing things such as breast ultrasound anatomy, technique and image quality, and then we're going to focus on how to report and things to look for when you're performing a breast ultrasound. So the first module today is going to be a review of anatomy on breast ultrasound. In our new BI-RADS manual, there's two subsections related to breast anatomy. The first has to do with technical issues, and they state that on your breast ultrasound, you must image to the chest wall to assure visualization of the entire breast. They updated this because when people were submitting ultrasound images for ACR accreditation, they realized that a lot of practices weren't showing deep enough in the breast. So you want to make sure in your ultrasound images that you're showing down to the chest wall, and we're going to review that in detail in the upcoming part of this lecture. There's also this new section related to tissue composition, and this is analogous to how we report breast density on mammography or BPE on MRI, or composition on MRI. And so they state that in a screening ultrasound, so if your group or your practice is doing screening breast ultrasound, you should state the tissue composition, and we're going to look at examples of these, but this can be homogeneous fat, homogeneous fibroglandular, or a heterogeneous tissue composition. And now we're going to move on to the technique portion of this lecture. So when we do breast ultrasound, you want to use a linear high-resolution transducer with a minimum frequency of at least 12 megahertz that has an adjustable focal zone. In our practice, most commonly, we use a linear transducer with an 18 megahertz minimum center frequency. You want to use a coupling agent such as gel if possible. You can get these little machines that keep your gel warm so that it's a little bit not so upsetting to the patient. You're not dumping cold gel on her, but we keep our gel in these little machines that just keeps it warm just for patient comfort. For very superficial lesions in the breast, these standoff pads are available. However, a nice blob of gel is easy to create the same effect as these standoff pads. So here I've shown you a lesion that's within the dermis. So again, here was that skin line we talked about. And within the skin, we have this very superficial lesion. So basically, these standoff pads or blobs of gels give you nice contrast for these very superficial lesions. So just a nice trick for a technique to use for very superficial lesions to see them better and better delineate their margins. Patient positioning is very important. So when we perform breast ultrasound, the goals of patient positioning are really two things. We want to minimize the breast thickness so we can see lesions well, and we want to create a reproducible image. And why we want to create a reproducible image is because very frequently I might be the doctor originally seeing the patient, doing her workup, finding the lesion and recommending it for biopsy. But it's not very common that I will also be the same doctor coming back and doing her biopsy. So just in case you're not doing everything for that patient and your colleague or your partner or another doctor may be coming in to do the biopsy, you want to make sure that they can, without a doubt, find the same lesion that you've documented and recommended for biopsy. So to do this in a woman with small breasts, it's pretty easy. It's more in the women who have larger pendulous breasts that it's really important to position them properly so that we can create a reproducible image. And what we do is, as shown in my graphic representation, we ask the woman to put her ipsilateral arm for the breast that you're scanning abducted and hand beneath the head. For a woman who has a large breast, for example, I've documented a lesion here that's in her outer breast. We always want the nipple to be pointed towards the ceiling, and that again is so that your clock face means something. You can see that if her nipple was pointed falling laterally or medially, your clock face and your distance from the nipple would be very variable. So in order, for example, in this lateral lesion in her breast, for her nipple to be pointed towards the ceiling, sometimes it's helpful to put a wedge under her that lifts the breast up and gets her nipple pointed towards the ceiling. So very important to make a reproducible image, and these techniques for positioning are very helpful. And now we're going to move into really the bulk of what I think is very important about reporting and different lesions we're going to see in the breast. So we're going to review how to label and measure images. We do this in two ways: in our report and on the ultrasound images themselves. And then we're going to go over what we include in our written report. So on your ultrasound images, on the machine and on the images themselves, you want to label where the ultrasound was performed, the date of the ultrasound exam, the patient name and their ID and or their date of birth, the operator's ID. So in our group, we always put the initials of whoever the doctor is doing the ultrasound, as well as the annotations for your lesions. So when we talk about annotations, you want to give a lesion location and the plane in which you're scanning. It's required that you document which breast this is, the right or the left, the clock face position, the distance of the lesion or where you're taking your image from the nipple, the transducer orientation, and optional to document your depth. I just want to make a note that when we document the distance of a lesion, it's from the nipple, not the areola. So how this graphic representation, this is incorrect. This would be documenting from the areola. We want to document from the nipple as we have here, and that's because the areola width can be widely variable. So you always want to document the distance of a lesion or your ultrasound image from the nipple, and they suggest estimating relative to the transducer face, especially in a small breast. I just estimate the distance from the nipple, but rulers work well too, and we keep some plastic rulers in our ultrasound rooms. I find this more helpful with a woman with a very large breast where I want to be more accurate to make sure that my colleague can find this same lesion. This old scheme of distance from the nipple in 1, 2, 3 and depths of the lesions in ABC, they've eliminated and don't want us doing this anymore. When we talk about transducer orientation, in most places in the body when we perform ultrasounds, we document in transverse and longitudinal, as you see in that graphic representation, which is okay. We choose to do radial and anti-radial. So again, radial, as you see here, where we're pointing towards the nipple, and anti-radial, where we're not pointing not towards the nipple. And we choose to do that in our group for a few reasons. We know that lesions within the breast tend to grow along those ductal systems, and that's going to be in the radial dimension. So you tend to see the true margins, the true extent of masses better when you do radial and anti-radial than trans and longitudinal. But either is okay. When we talk about lesion measurement, when you want to measure a lesion, the caliper placement, the frame of reference should be your mass, not the rectangular frame of your ultrasound image. So here you see that our calipers have been placed correctly. They're along the largest axis of the lesion. This is a correct way to measure something on breast ultrasound. This would be incorrect. Here we placed our calipers relative to our ultrasound image, so this is incorrect. Again, you really want to measure based off the mass itself. We want to give 3 dimensions when possible, a minimum of 2. For example, here, when we can't really measure in this direction because of the posterior acoustic features, but at least 2 measurements, and often we can get 3 measurements for our lesions in the breast on ultrasound. So again, here's correct. And how you report them, they want you to do the longest horizontal by vertical by the orthogonal horizontal. So the view in which the lesion is the biggest is the view in which you, or the plane in which you want to obtain the 2 measurements. And in the shorter plane, you're going to get a single orthogonal horizontal measurement. So as far as the images we take and measurements, you want to take all images with and without calipers. So usually what I do, if I see a mass in the radial plane, I'll freeze my image, I'll take a picture, and then I will measure that frozen image and also obtain an image with calipers. You want to measure to the closest millimeter. And if you go in to do a follow-up exam or a biopsy, and if your location varies slightly from the prior exam, if it's just minimal, you can just report that as per prior to stay consistent, that we all know this is the same lesion we're documenting, or you could report the new location with explanation of why it might be slightly different, such as differences in technique or positioning. All right, so moving on to the written report. Again, this is kind of going to be the bulk of this talk. We talked about scope and technique and breast tissue composition. These are the new the new sections in the written report for BI-RADS, and this is some of the stuff we're going to go over. When we talk about scope technique, in your report you should just state whether this was a targeted breast ultrasound, so you're working up a finding of mammography or a site of clinical concern, versus a supplemental whole breast screening ultrasound. You want to talk about who did this. Was it a sonographer and a physician, the physician alone, or if it was automated, if you use Doppler or elastography, and if helpful, to discuss how the patient was positioned. You want to give a clear description of your important findings in order of clinical relevance using locations and measurements, as we just went over, and your BI-RADS lexicon. And I'm going to talk about some of the changes in the most recent BI-RADS edition, which has been modified to attain similarity across all breast imaging modalities, so ultrasound, mammography, and MRI. So here's our BI-RADS breast ultrasound lexicon, reviewing masses, calcifications, special cases, vascularity assessment, and category. And this was the first edition, originally published in 2003. Looking at the second edition in 2013, we have multiple changes, and we're going to review several of these today. So when we talk about masses in the old lexicon versus the new, there has been a slight change, and that's oval now includes anything with 2 to 3 lobulations, or what we previously may have called macrolobulated. So if something has 2 to 3 gentle lobulations, we're going to call that oval in shape. Our other shape descriptors on ultrasound are round or irregular. When we talk about orientation, again, we're going to talk about whether a mass is parallel to the skin surface or not parallel. Mass margins, we still have circumscribed and not circumscribed. However, we have taken out this term echogenic rim as its own thing, or we used to call it echogenic halo, and now that's under the indistinct margin. So we have, if a lesion is not circumscribed, the margins are now indistinct, which again includes that echogenic rim, angular, microlobulated, or spiculated. And so this previous term, echogenic halo, has been dropped and replaced by echogenic rim, which is now included in the indistinct margins because they say one might not be able to distinguish. So here's just a nice example of a mass with somewhat indistinct margins. It's hard to draw a definite circle or border around this very suspicious hypoechoic lesion that was a breast cancer. Talking about echo patterns of masses, we still have anechoic and hyperechoic. The previous term complex has been dropped and replaced with heterogeneous, and we have this new term of complex, cystic, and solid, and we still have hypoechoic and isoechoic. So let's take a look at this. So this on the left is an example of this new echo pattern called complex, cystic, and solid in this complex, cystic, and solid mass with internal vascularity that would warrant a BI-RADS 4, and you'd want to recommend a sampling of a lesion that looks like that. A heterogeneous echo pattern is demonstrated on the image on the right. When we talk about posterior acoustic features, there's been no changes. A lesion can have none. It can have posterior acoustic enhancement, which we think of as often seen in cysts, but not diagnostic for a cyst. Posterior acoustic shadowing, which is often very worrisome, or a combined pattern. When we talk about calcifications, now as opposed to defining macro versus micro calcifications like we did in the old BI-RADS lexicon, now we talk about where calcifications are in relationship to whether they're in a mass, outside a mass, or if they are intraductal. So let's take a look at some examples. So here are some calcifications, these bright white echogenic foci. That's what calcifications look like on ultrasound, and they're in this somewhat indistinct mass. Calcifications can also be outside a mass, as they are here. Again, these echogenic bright white dots represent calcifications on ultrasound, or they can be intraductal, as we see here with these calcifications within these ducts radiating towards the nipple. I just want to make the point that per the ACR practice guidelines for breast ultrasound, when we talk about calcifications on ultrasound, evaluation of microcalcifications suspicious for malignancy or highly suggestive of malignancy, we do ultrasound in these cases to look for an underlying mass that could possibly be obscured, and we do ultrasound to see if we could possibly sample these under ultrasound guidance. This is an easier biopsy for our patients than doing biopsies such as stereotactic biopsy under mammographic guidance. So again, we do not have the resolution to characterize calcifications on ultrasound. You really need your mammography and your spot magnification views for that. But we do ultrasound to look for an underlying mass or to see if we can sample these calcifications with ultrasound guidance, which is much easier for our patients. We have an associated features in the ultrasound guidelines, just some changes. Cooper's ligament changes have been dropped, and that's now included under architectural distortion. And we have these new categories of vascularity and elastography. So in our old associated features, we had this term Cooper's ligament changes, but now that's all included under architectural distortion. As we see here, where we see the spiculated mass causing architectural distortion and tethering of those Cooper's ligaments. Since it's truly kind of the same finding, we just wanted to simplify things, and now we just comment on architectural distortion in this lesion as we see here, which was an invasive ductal carcinoma. When we talk about vascularity, in the old BI-RADS, it said we could say it was not assessed. Now we have to always assess for vascularity when we see a lesion within the breast. You can say it's absent, internal vascularity, or this new term, vessels in a rim, as we see in an abscess. I just want to make a comment about vascularity, and that's that no vascular pattern is specific for any particular diagnosis. It's highly dependent on technical factors. So on this top image, we see this oval circumscribed mass that appears very vascular, and this was a benign fibroadenoma on biopsy. This is as opposed to the image on the bottom where we see this hypoechoic spiculated mass with no real internal vascularity, and that was actually a cancer. So just to make a comment that a lesion like this that's suspicious that we don't have vascularity, that's still suspicious, as sometimes these cancers, when they've had a lot of inflammatory reaction, a lot of desmoplastic reaction, might not have much vascularity. So you always want to assess for it, but don't be thinking that something's benign just because it doesn't have any vascularity demonstrable. To optimize your sensitivity, you can use power and energy Doppler, decrease your scale, or use low flow settings. So let's take a look at this example. We talked about earlier how compression is important to really make sure that posterior acoustic shadowing isn't artifactual. The one comment is if you use a lot of compression, you could occlude flow a little bit. So here's this hypoechoic mass, the image on the left. We're using a lot of compression, and we're barely seeing any vascularity in that lesion. But when we release compression a little bit, we actually see that there's a lot of vascularity within that lesion, as shown on the image on the right. All I've changed between these two images is releasing compression a little bit. So just make sure that you aren't using so much compression that you're occluding flow to the lesions. You want to size your color Doppler box to the region of interest. So on the left here, my color box is the whole screen. This is way too much. We're making it a little smaller here, but this is appropriate. That box is right around that mass. And we see that this is very vascular, so when we adjust our color Doppler box appropriately, we nicely see the true vascular pattern of this breast mass. So just something technical to be aware of. Moving on, in our second edition, we have all these categories. We've covered that first half, and now we're going to move on to the second half, and we talk about special cases, and I've highlighted in yellow some of the new changes in the second edition for breast ultrasound lexicon. So let's start by talking about simple cysts. These are by far and away the most common breast mass. We see them both in pre- and postmenopausal women, especially postmenopausal women if they're on hormone replacement therapy. We see them more commonly in premenopausal patients. So just something to be very aware of and very familiar with. Simple cysts, of course, are a benign lesion. These should be circumscribed, oval or round, anechoic with posterior acoustic enhancement, as we see here. Again, so these cysts have these increase through transmission as we send our sound waves in and send them through the lesion. We have increase through transmission, causing this nice posterior acoustic enhancement, this bright white behind the lesion. Now, another thing that's helpful, particularly if you have a small simple cyst, you might not always see that posterior acoustic enhancement, but what you do see, and what's very specific for a cyst, is this hyperechoic, this bright white posterior wall. And that may be what we see in smaller cysts without significant posterior acoustic enhancement. Here's a nice example, and again, these simple cysts should have no flow on Doppler. If you think something's a cyst, it's anechoic, it's circumscribed, you always need to verify that there is no flow on Doppler. Something to be aware of is what we call near field artifacts. So occasionally, let's go back, you might see in the near field kind of some hypoechoic area. It's often very well defined and linear, and this is possible, and this is just artifactual. Just be aware that near field artifact is going to look like that, but if all the other characteristics meet the criteria for a cyst, this has no vascularity, it looks very regular, it's artifactual, and this is still a simple cyst. Harmonics are helpful to resolve artifactual echoes, but again, you want to keep your gain appropriate. You never want to make a solid mass look cystic by adjusting your gain inappropriately. So simple cysts, something we should all be very familiar with. These are very commonly seen. They are a benign finding and a BI-RADS 2 lesion. Now let's move on to review clustered microcysts. This is another type of cystic lesion we see within the breast. These are a common incidental findings in a study by Berg published in AJR. She found them incidentally in almost 6% of ultrasounds. So what are clustered microcysts? Well, let's go back to this graphic representation of the anatomy on breast ultrasound. So we have our terminal ductal lobular units, again, where a lot of our breast pathology lies. And if we look at these again in cross-section, what clustered microcysts are is when you get cystic dilatation of these TDLUs, making this clustered microcyst appearance. These are defined as microlobulated or oval masses composed of 2 to 3 millimeter cysts with thin intervening septa and no discrete solid components. So here you see a beautiful example, this duct kind of leading up to these clustered microcysts. Here's another example. This one was a little less obvious. We were wondering, could this possibly be a solid component? We put on harmonics. It really clears that up. Those were artifactual echoes. We've kept our gain appropriate. Our fat lobules are still a medium gray, but here we've cleared this up. It's clearly cystic in nature, compatible with a clustered microcyst. Cine clips can also be helpful. So here when we do our cine clip, we see nicely that these are a nice example of clustered microcysts, these cystic dilatations of our TDLUs. One more nice example. Now, per BI-RADS, if these are a classic example, clearly composed of simple cysts, these may be a BI-RADS 2. If they are small or deep, you may want to give these a BI-RADS 3 if there's any diagnostic uncertainty. But these should undergo sampling and be a BI-RADS 4 if you can't rule out a solid component, or if there's any suspicious clinical or mammographic finding. For example, this is new in a postmenopausal woman who is not on hormone replacement therapy, or if it's shown rapid growth. Now let's move on to talk about another type of frequently encountered cystic lesion on breast ultrasound. We have complicated cysts. These are cysts that are not simple, and they are typically the result of a benign etiology such as fibrocystic change, trauma, lactation. They may contain blood, protein, milk, foam cells, fat. Basically, these are cysts that contain some sort of debris. The ultrasound features, well, they have the same features as simple cysts that we just reviewed, but they also have these mobile internal echoes as we see here. Again, all the features of simple cysts, but this is not completely anechoic. We see these little mobile internal echoes floating. Here's another example. We see those mobile internal echoes and kind of this debris level as we see here. Here we again have that fluid debris level, and to make sure this isn't solid, a tip to you is to move the patient. So if here she's lying supine on her back, I may have her go into a lateral decubitus position, as I've done here, to ensure that all those mobile echoes truly are mobile, that they're moving around dependently, and it's not a solid component. And again, here we show that these are moving dependently. So when we talk about complicated cysts, you can dismiss these as a benign, a BI-RADS 2 if you have multiple bilateral complicated cysts, at least 3 overall and at least 1 in each breast. Most frequently, you'd be seeing that if you were doing a screening breast ultrasound. If you have an isolated complicated cyst with uniform low-level echoes, that is the case in which you might give that a BI-RADS 3 and recommend short imaging surveillance. However, if there is any diagnostic uncertainty and you can't rule out a solid component, that should be a BI-RADS 4. Now, when we talk about isolated complicated cysts, we have over 1,000 cases documented in the literature with 4 malignancies or a 0.3% malignancy rate, and that's where we come to the BI-RADS 3 assessment. Now let's move on. You can also have cystic lesions within the skin. So here we have a cyst in the dermis, and sebaceous cysts like we have here. Again, here's that skin lesion, and we've used that blob of gel to get that nice contrast with the superficial lesion. These sebaceous cysts are actually going to be hypoechoic. They're not often anechoic, but we see that claw sign. We see that this is definitively a lesion within the skin. This is a benign BI-RADS 2 lesion. Another helpful sign is this gland to the neck. We see this tract, a gland neck. It's a tract to the skin. I always look at the patient's skin. I turn on the lights. As radiologists, we're used to being in the dark, but we'll turn on the lights. We'll look at the patient's skin, and very frequently you can see this little pimple or indentation from this lesion, and that's where this tract is going to the skin. Epidermal inclusion cysts are another type of skin cyst. These tend to be heterogeneous with concentric echogenic layers, as we see in this image. But again, we kind of see that claw sign. Any lesion you can definitively define as being in the skin may be dismissed as a BI-RADS 2 or benign finding. And just a note, you always want to evaluate with color. This should not have significant flow. If it does, you may need to recommend a biopsy to confirm that it is in fact a sebaceous or epidermal cyst. If there's any vascularity, I would recommend tissue sampling. But when these are classic, no vascularity, you can see a claw sign, a tract to the skin, you can see it within the skin. Again, these are benign BI-RADS 2s. So these cystic lesions that we've reviewed, which are mostly benign, are in contrast to the complex cystic and solid mass. Up to a quarter of these are malignant, so these are a suspicious finding that you need to recognize, and they need to undergo tissue sampling. These are cysts with thickened walls or septas. So here we see this very thick wall, very thick septa, eccentric thickening or mural nodules, as we see here. These are very suspicious findings. Again, up to a quarter of these are going to be malignant, so these really need to go under sampling. Here's some other examples. These are cysts with solid components. They can be predominantly solid mass with extensive cystic change, or here where we see a predominantly cystic lesion with this very irregular solid component. The only caveat to this is if they've had a known recent intervention. So for an example, this patient who had a benign biopsy 1 week prior and got this large hematoma, this is a retracting clot, and you can follow this to resolution. And it doesn't mean to definitely undergo biopsy right away, because she has a clinical explanation, and this could just be hematoma and retracting clot. All right, moving on, there's a section on foreign bodies with different things listed here. We're going to take a minute to talk about implants. So MRI is truly going to be the gold standard for evaluating implants. However, ultrasound is a much more readily available exam, particularly around the world, and you can look for complications of implants by using ultrasound. So let's take a look at what implants look like on ultrasound. Saline and silicone are going to look similar. They're going to both look hypoechoic when intact, as in here. You're going to see the envelope. That's going to be these parallel echogenic lines. The implant capsule is typically occult. We don't really see that on ultrasound, but you will see the envelope. Again, those parallel echogenic lines of the envelope. Here's just a nice example of what a normal radial fold looks like. It's very common to see these. This is a normal finding. A small effusion, sometimes we'll see small amounts of fluid. A trace amount of fluid around an implant can be a normal finding. We're more concerned if there's a significant amount of fluid around the implant. Here, let's take a look at what we have here on the cinnate clamp. Again, those parallel echogenic lines, but here we're seeing a focal herniation of that implant. Here's an example where I can tell what kind of implant this is, because here, I'll give you a minute to look at that. Again, that's just a nice example of what a valve looks like on an ultrasound of an implant, as we see in saline implants. Again, silicone implants don't have valves. This is diagnostic for a saline implant. And sometimes patients come in, especially if they've lost a little weight and they have a new palpable lump, and not infrequently, they're actually just feeling the valve of their saline implant. So something to be familiar with. If a saline implant ruptures, you don't really need to do any sort of imaging workup for that. It's going to be clinically apparent. However, I've just included some examples of what that will look like on ultrasound. So on the top is a prepectoral saline implant where we see these stacked echogenic lines of the envelope, but it's completely collapsed, and it's in front of the pectoralis muscle. The example in the bottom image is a collapsed retropectoral saline implant where we see those stacked echogenic lines. Silicone implants are where we need to help the referring providers. Silicone implants, when ruptured, this is what an intracapsular rupture. So the implant has ruptured but is contained within that capsule. So here we see what's called the step-ladder sign, and this is equivalent to the Linguini sign on MRI, compatible with an intracapsular silicone implant rupture. I just want to make the point that extracapsular rupture will have a snowstorm appearance. Now, don't be confused with that implant rupture or intact implants that can have near field artifact like simple cysts. So that's what that looks like. But that's as opposed to this implant that's ruptured, where we see the snowstorm echogenic appearance of extracapsular free silicone. Also of note, silicone that has ruptured outside of the capsule can migrate to the lymph nodes. So this is actually a cinnate clamp of the axilla, where within these axillary nodes we see the snowstorm appearance of silicone that's ruptured and migrated to the lymph nodes and is contained within the lymph nodes. So this is also compatible with an extracapsular rupture. And here again, here's that thin cortex of the axillary node and some snowstorm appearance related to the silicone within that node. Some places do silicone or paraffin injections free into the breast. This is illegal in the United States, but not in all countries. So you might see this diffuse snowstorm appearance or thick-walled cysts, and this is related to injections into the breast. And this is what that would look like on mammography. And we went over this in the calcification lecture a little bit. Vascular abnormalities we may also see in the breast on ultrasound, such as AVMs, pseudoaneurysms. These can be idiopathic or congenital or iatrogenic. Mondor's disease is something they talk about in the breast. What this is a self-limiting superficial thrombophlebitis, as we see here in this image from the internet. What this presents like is a cord-like palpable abnormality in the breast. This is a benign finding, and this usually resolves on its own. Sometimes anti-inflammatories or warm compresses can be helpful for these patients for symptomatic relief. You can also have post-surgical fluid collection, seromas, and hematomas. These require reference with clinical history. Again, in this case, this was a patient who'd recently had surgery, and this was just a seroma. To be dismissed as benign. There was no vascularity within this lesion, which we confirmed. Fat necrosis may present as indistinct increased echogenicity, as we see here. It may or may not have cysts, as we see here, this increased echogenicity in this little cyst. And in later stages, it can be these thick-walled cysts with wall calcium. However, this is a very nonspecific finding. A cancer could look just like this, so you really need to require reference with clinical history and really need to confirm with a mammography image, as we see here in this classic appearance of fat necrosis, that was benign fat necrosis, nothing to worry about. So I want to thank you for your attention with that. And just moving on very briefly to 2 slides. The first for Module 5 on what a healthcare worker should know about this topic. Well, I think in several places, ultrasound is going to be much more readily available than any other breast imaging examination, such as mammography and MRI. Ultrasound is a fast, low-cost technique that is very, very helpful to us as mammographers. It is very frequently used both to make diagnoses. Is a mass cystic or solid? Is there something concerning at the site of patient or physician's concern in the breast? We're able to tell solid masses versus cystic lesions. We're able to characterize lesions. What we're really looking for are hypoechoic solid masses that may represent cancer. These have a varied appearance, spiculated margins, but high-grade carcinomas on ultrasound can have very benign looking margins. They can be hypoechoic circumscribed margins, particularly in our very high-risk patients. So we use ultrasound really to define if something is cystic or if it's solid. And good ultrasound technique that we went over earlier in the lecture is absolutely essential to accurate diagnoses. And the last module, what should a patient know about breast ultrasound? Well, a patient should know that ultrasound is very commonly used in breast imaging. It helps us better look at spots that either we're seeing on a patient's mammography or if the patient is concerned, for example, for a palpable abnormality. It's based off sound wave technology and has no associated radiation. So unlike mammography, there's no radiation involved. Unlike MRI, the patients don't need to get contrast. So it's very minimally invasive or not invasive at all. There's really no risk for a patient to get an ultrasound. If a woman is less than 30 years of age, ultrasound is going to be our first imaging tool to evaluate breast symptoms such as focal pain, breast lumps. If a woman is over 30, when possible, we start with a mammogram, and then we'll move on to ultrasound for further evaluation of your breast symptoms. Ultrasound is also going to be the most frequent imaging guidance for breast biopsies. So for you as a patient, if you need a breast biopsy, ultrasound truly is going to be the easiest modality. It's cost effective. The patient's able to lie on his or her back, and they're not in compression, and they don't have to get contrast like in an MR guided biopsy. So with that, I would like to thank you very much for all your attention today, and that's going to conclude our lecture on breast ultrasound.